Thank you, Alessandro, for the kind introduction. Before I start, let me thank the organizing committee, and in particular, Sandro, Carlo, Peter, and Robert for their very kind invitation. It's a great pleasure and honor to be a part of this meeting. So this is my disclosure. So the first question that I would be addressing is how often the POSEIDON patients are seen in the fertility clinic in routine daily life. So those patients fitting to group 1 and 2 POSEIDON right now are initially described by the Italian studies by Placido in 2001, 4, and 5. And at that time, the long protocol, the depot long protocol, the follicular long protocol was used. And with a daily FSH dosing of 150 to 300, the initial inadequate response during ovarian stimulation with REC FSH was defined as on the 8th day of ovarian stimulation, if the E2 was less than 180 picogram per ml, and with no leading follicle, in the presence of 6 antral follicles, it was referred to as initial inadequate response. And such a response has been reported in 12 to 14% of expected normal responder patients. And in those studies, the expected normal responder was defined as if the day 3 FSH was less than 10 IU per liter. The terminology unexpected was first used by the Dutch study by Klinken et al. And of the 1,307 cycles, the first IVF treatment cycle, 12.7% of the cycles were reported to be unexpected. And in order to fulfill the definition of unexpected, the female age should be less than 41 plus the day 3 FSH was less than 15 IU per liter. So it was the first definition of unexpected poor response. And those patients, we do know that they fit to POSEIDON group 1 and 2 patients. So I would like to share, you have already heard about this and the prevalence study. I would like to quote the multi-nation, multi-center prevalence study. The 3 centers was the Androfert, directed by Sandra Steves, Professor Len Wong from Vietnam, and ours, the Anatolia IVF. And with this opportunity, I would like to acknowledge Sandro for doing the majority of work. Thank you, Sandro. So those patients were consecutive patients, 22, 4 to 6-year-old, during a 2-year time period. The first cycles were enrolled. The standard ovarian stimulation with gonadotropins, and only 1 cycle per patient was included. AFC was used as the ovarian reserve biomarker, and both the agonist and the antagonist protocol, either recombinant FSH monotherapy or some with LH activity, either recombinant LH or STG-driven LH activity were used. And these are the features, the baseline demographic features of the POSEIDON and the non-POSEIDON, the counterparts. But shortly, as might be expected, the female age was higher, the BMI was higher, the duration of infertility was longer, and the ovarian reserve was less in the POSEIDON group. And despite the retrieval of significantly less oocytes, this was at the expense of significantly higher total gonadotropin dosing. And the agonist protocol was more commonly employed in the POSEIDON group, and also some form of LH activity was also more commonly used in the POSEIDON group. Although there were slight differences in the prevalence rate of the POSEIDON group, it was 56% at Androfert, 49 at Anatolia, and 39% at the My Dak Hospital in Vietnam. But the figures were consistent. So overall, of all the patient population cohort, 43% fulfilled the definition of POSEIDON. Among the POSEIDON groups, group 1 and 2 constitute the majority, 80% of the cases were indeed group 1 and 2, followed by group 4, constituting 15%, and lastly, group 3 patients constituting the 5% of the whole cohort. So assuming that in the whole cohort, it is 43%, and if you multiply this by 80% group 1 and 2 patients, so it comes to 1 out of 3 patients. 1 out of 3 patients presenting the fertility clinics indeed fulfill the definition of group 1 and 2. And among group 1 and 2 patients, so how was the prevalence rates for the 1A, B, or 2A and 2B? In group 1, it was the majority, around 91% was B, group B, and also the same trend for group 2 cases. So around 85% actually were 2B, and the remainings were 1A and 1B cases. So the second objective was, what are the features that are significantly associated with the POSEIDON state? And in order to do that, we had to do the logistic regression analysis and taking the dependent variable as the POSEIDON state, and we checked all these parameters. And the female age, BMI, antral follicle count, and the presence of a primary treatment factor, female factor, were actually the independent predictors of the POSEIDON state. And there was also a center effect. But we should all keep in mind that these relations with these explanatory variables and the POSEIDON state are only associations, and we cannot make a causal relationship. So making a more detailed analysis, doing, once again, the logistic regression analysis, and what are the factors to predict the group 3 and group 4 cases, the female age, BMI, and this time duration of infertility, and once again, the female factor were all independent, significant predictors of group 3 and 4. And this time, there was no center effect. And regarding the, once again, doing the logic regression analysis for the independent predictive factors for group 1 and 2, the 4 factors is the whole POSEIDON group, the female age, the BMI, antral follicle count, and the female factor. In addition to these factors, this time duration of stimulation, the use of the antagonist protocol, and using some form of LH activity were also associated with the group 1 and 2 cases. So to make an interim conclusion, 40% of patients undergoing IVF with standard ovarian stimulation are classified as POSEIDON. Among them, 80% are groups 1 and 2. And despite varying across study centers, the prevalence rates are fairly consistent. And POSEIDON patients are older, slightly heavier, and have a lower ovarian reserve. And non-female infertility factor is more frequent in POSEIDON patients than in their non-POSEIDON counterparts. And despite larger doses of gonadotropin consumption, the oocyte yield is 2.5 times lower in POSEIDON patients than in non-POSEIDON patients. And there are not too many studies available in the literature looking at the prevalence of the POSEIDON state. And this study from China reported an overall prevalence of 31.5%. However, in that study, there was no control group, so we cannot make the comparison which factors would be predictive of the POSEIDON state. And in a more recent Chinese study, overall, the prevalence was reported to be 20%. But in this study, rather than the patients, the cycles were included, and some patients underwent more than one cycle, so it is difficult to make the estimation because the state should be based on per patient rather than per cycle. And the overall prevalence was 20%. So having said this, we should also keep in mind that the prevalence rates may be affected by patient characteristics, diagnostic criteria, and also clinical practice. Regarding the patient characteristics, very shortly, just sentence, the access to ART, referral to ART, the reimbursement policy, and socioeconomic factors, income, education, occupation, they may all impact the prevalence rates. And also, apart from the biomarkers, we have already heard about the polymorphism of the gonadotropins and their receptors. And racial ethnic disparities, very interesting studies, not only affecting the ovarian reserve, but also prognosis of the IVF outcome, and differences in ethnicity might also contribute to differences in the prevalence. Also, differences in BMI, the smoking status, androgen levels, the infertility diagnosis, they may all impact the ovarian response, and hence, such differences might be resulting in differences in the prevalence. Also, diagnostic criteria. Today in the morning, we have heard about the tools, the AMH and antral follicle count, but very shortly, this is also our study looking AFC and AMH to classify POSEIDON patient, a classification agreement study over 9,000 patients. And when you form the contiguous table, the kappa scoring is 0.8. Kappa scoring is a metric to evaluate the clinical agreement or clinical disagreement. If the kappa scoring is greater than, it should be greater than 0.5. If it is closer to 1, it means perfect agreement. And so using these two biomarkers, assigning the patients with different groups, the kappa scoring is 0.8. But moreover, if you classify the patients as POSEIDON or non-POSEIDON, the kappa is near 1. So quite good agreement exists between two biomarkers. And as I've already been quoted, and with the ROC curve analysis for the yielding of less than 3 oocytes was less than 4 oocytes, the cutoff value was 5 for AFC and 1.27 for AMH. And for the first time, the cutoff points, the optimum cutoff points as revealed by the ROC curve analysis was defined for suboptimal response, and these were 12 for AFC and 2.97 for AMH. But we should keep in mind that, as also very elegantly expressed today in the morning, there is still no international standard for AMH. And different assays still, or different even automated assays, still produce different results. And AMH, the results of AMH assessment should be assay-specific. And those automated assays produce lower values compared to the manual ELISA assays. And at that time, the manual ELISA, Beckman Coulter 2 manual assays were performed. So these thresholds might be changing over time. So what about the clinical practice? The clinical practice, the type of gonadotropin and also FSH dosing might also affect the prevalence. And there are 3 studies which I would like to quote in this context. And the first study is a small proof of concept RCT with the FSH receptor serine for those homozygous patients. If you increase the dose, the REC FSH dose from 150 to 225, and the primary endpoint of this study was the E2, which might not be relevant in clinical practice. But anyhow, if you increase the dose from 225, from 150 to 225, you would overcome this deficiency. And the other study, the French study, using the depot GNH agonist protocol, if you use the starting dose of FSH as 300, the antral follicle responsiveness to FSH, as measured by Ford, would not be influenced. So obviously, the take-home message of this study should not be using the starting dose for 300 for all patients, because you might be ending up with hyperstimulation, and also it's not cost-effective. But at least increased FSH dosing might be overcoming the resistance due to FSH receptor polymorphism. And more recently, the Dracopoulos from UC Brussels, using the antagonist protocol, using the 150 starting dose, the constant dose of 150 recombinant FSH, if you end up with suboptimal response, retrieval of 4 to 9 oocytes, and if you take all those patients to undergo a second treatment cycle within 1 year, and this time, based on the physician preference, either using the same dosing, 150, or increasing the dosing up to 300, then they concluded that an increase of 50 IU of the initial rec FSH dosing in the second cycle in those suboptimal responders would lead to more oocytes. Having said this, I also would like to, go through, with your permission, to the statistical phenomenon, which is called as regression to the mean. And in this context, I would like to quote two events. The first one is a teacher laments when I praise my students for good work. The next time they try, they tend to be less good. However, when I punish my students for producing bad work, the next time they try, they tend to do much better. Therefore, punishments work, but rewards do not. The next example is a film critic stipulates, winning an Academy Award, the most prestigious prize in show business, can lead an actor's career to decline rather than to ascend. So having given these two examples, I would like to talk about this regression to the mean. And in real life, what happens is that the extreme, atypical events are followed by more typical and less extreme events. This is a statistical phenomenon, and it's called the regression to the mean. So let's go to one more example. And before, the success equals to the talent plus luck. So in year one, we have two students. Jane does horrible. He's in the lowest 1%. However, Joe does very good. He's in the 99% of the class performance. So in year two, if the success or failure of Jane and Joe are completely due to 100% to talent and 0% to luck, they would have the same performance, exactly the same performance, with no regression to the mean. However, consider the possibility B, if that luck in year one was due to 50% talent and 50% luck, then Jane would regress to the 25%, and Joe would go down to 75%. For the possibility C, if, there was no, in year one, the talent, the responsibility was 0%. If the luck was 100% responsible, then they would go all regress to 50%. It's like the flipping the coin. So in real life, the events are more or less a combination of talent and luck. Very rarely it is 100% talent. So coming to, if the student does very well in the first exam, but in the second exam, the quality of exam might not be superb. Not all the exams are of the same quality. And the student might not have slept well. He might not be in good mood. And therefore, there is a responsibility of the luck phenomenon. And therefore, there might be regression to the mean to some extent. And also, this also happens for the actor. Apart from the actor's performance, the quality of the scenario, the quality of the director, the team, the chemistry of the team, they all come together to dictate the final performance. So it is not the intervention in the first example. The intervention is the praising or the punishment, nor the event itself per se are responsible for the failures of success. But our memories all the time associate the prior events or prior intervention as the causation of the second event. And this is a very important source of bias for before and after study designs. And obviously, ovarian stimulation, obviously biological events are open to random fluctuations around the mean. And ovarian stimulation, ovarian response to ovarian stimulation is a very good example in this context. And trust trial is a perfect illustration of the regression to the mean. And in normal responder patients, using the antagonist protocol, using the long-acting recombinant FSH preparation, the same patients, using the same protocol, the same drugs, undergoes 3 treatment cycles. As you can see, from first to second cycle, some normal responders in the first cycle, they jump to the high response, and some to low response, around 12%. And some high responders come to normal, and some low to normal response. So around 25% of the cycles, they change the classes. And that also applies from second to third cycle, and also from the first to the third cycle. So to conclude with, even using the same protocol, the same medication within an acceptable time period, the same patients, 1 out of 4 patients can switch the response category. And coming back to the clinical, the Dutch study with cycle 1, the multiple cycles, cycle 1, cycle 2, and cycle 3. In cycle 2, at that time, you can see the median dose is 2.1 or 4.0. It was at that time the number of vials. So you need to multiply by 75. So you can clearly see that. You can clearly see that. I'm sorry. You can clearly see that from cycle 1 to cycle 2, when you increase the dosing, 64% respond normally. And the cycle 3, 83% respond normally. Even the patient responds poorly in the first and second cycle, still 52% can respond normally in the third cycle. So this is an example for before and after study design. Before and after study design. And obviously, whether these favorable results, differences, with increased FSH dosing, are they due to regression to the mean? or at least in partly, due to increased FSH dosing, cannot be elucidated with this study. And in order to make this elucidation, we should be doing a randomized controlled trial. And in hyporesponder patients, say with a standard dose of 150 recombinant FSH, the second cycle, for those patients, 150 or increased dosing with an RCT, you can make the distinction. And such a study has not been conducted. And also, not infrequently, this regression to the mean is ignored in medical practice. And one of the examples is these Chinese papers. And increasing the medication, changing the IFO protocol, you end up with increase, 4th and 4Es in the consecutive cycles. But obviously, this might be in part due to increased FSH dosing, but regression to the mean should also be taken into account. And very recently, in human reproduction, this paper has been, Human Reproduction Open has been published with, increasing FSH dosing. The authors conclude that the current study found no significance in live birth rate per embryo transfer when POSEIDON groups 1 and 2 were compared with non-POSEIDON group, which mainly consist of women with a good prognosis. However, the live birth rate per embryo transfer was significantly lower in the POSEIDON group 3 versus the non-POSEIDON group. But more importantly, as I highlighted, the increase in gonadotropin dosage with or without protocol change was the main modification in POSEIDON group 1 and 2, which resulted in, which is hard to say, in treatment outcomes that were comparable to non-POSEIDON groups. So to conclude with, regression to the mean should be considered in before and after study designs. Ovarian response are subject to random fluctuations above and below a mean. The impact of increased FSH dosing in hyporesponders should be evaluated by RCTs, and differences in clinical practice. If that is the case, then differences in clinical practice regarding FSH dosing may impact the prevalence rates. So I didn't put a slide on the type of gonadotropin, as was also clearly indicated during the previous sessions. Some form of LH activity may be overcoming the hyperresponse in group and 2 patients with some, receptor polymorphisms, and differences in practice regarding adding some LH activity in all patients might also be resulting in differences in prevalence. And finally, how to avoid the POSEIDON state, awareness of impact of female age on reproductive potential, BMI, lifestyle, and pharmacology and treatment on polymorphism gonadotropin and their receptors, which is the feature of ovarian stimulation, might be the measures to avoid in the POSEIDON state. And finally, repeating as was I will be repeating, which I already talked about in the interim conclusion, 40% of the patients undergoing IVF with standard ovarian stimulation are classified as POSEIDON. Among them, 80% are group 1 and 2. Despite varying across study centers, the prevalence rates are consistent, and further prevalence studies are warranted controlling patient characteristics and clinical practice. POSEIDON patients are older, slightly heavier, and have a lower ovarian reserve. A non-female infertility factor is more frequent in POSEIDON patients than in non-POSEIDON counterparts. And despite larger dose of gonadotropin consumption, the oocyte yield is 2.5 times lower in POSEIDON patients than in non-POSEIDON patients. And finally, improved awareness of the impact of female age and BMI on reproductive outcomes and pharmacodynamic approach for ovarian stimulation may decrease the POSEIDON state. So, thank you.